Welcome back to another episode of Oncology for the Inquisitive Minds. And in the words of Samuel L. Jackson from Jurassic Park, hold on to your butts because this is going to be a long one. I am here, as always, with the very dapper medical oncologist Josh Hurwitz, who I think has really stepped up his fashion game since we've got onto YouTube. He's looking very smart. Josh, are you feeling as smart as you look?
I don't know how to answer that. We'll say yes.
That's correct, because Josh is one of two brains behind this operation. So in case you weren't aware, because you somehow missed the title of this video when you were clicking on it, we are coming a little late to the party, but we are going to start our ASCO sojourn. Now, in previous years, we have dragged this series on so long that it's been the time for the next major conference by the time we finish, but we are going to do our best to keep it nice and short, keep it concise and condensed for your listening or viewing pleasure. So we've broken up the ASCO series into 3 episodes, the first of which is today. This episode focuses on agents for the present. And that is studies that were, by definition, not plenaries. We've got a separate episode for that allowing for regulatory differences, have enough to make us excited for their use in medical oncology in the present or the near future. Next episode, we'll be focusing on agents for the future, where, there are some questions that need to be answered, but they're exciting directions. And then finally, we come to the big guns, the plenary episodes. And it was, Josh, it was good eating at ASCO this year, I thought.
Does anyone say good eating, Michael?
It was good eating. I'm branching out to our American listeners / viewers.
What do we start? We get an hour's worth of content to smoosh for more than an hour.
We do indeed.
Yeah.
We do indeed. So, yes, without further ado, let's roll. So, the first study, as I just get these slides up, we've got a number of slides for most of our studies, but not all of them. So, start the timer, Josh. Our first study is a update on EV302. Now, this is the study of first-line enfortumab vedotin, the Nectin-4 inhibitor, plus pembrolizumab in advanced or locally advanced or unresectable or metastatic urothelial cancer. We've talked about this study on this show in the past. It is absolutely practice changing, but what was presented at ASCO was a median 3.5-year follow-up and exploratory subgroup analysis for patients who had achieved a complete response after an initial partial response. So interesting stuff. So here are the methods. As I said, we've spoken about this fairly in depth in previous episodes, but in brief, patients were randomized 1-to-1 to receive EV plus Pembro or cisplatin /carboplatin or gemcitabine. The dual primary endpoints were PFS by blinded independent central review and overall survival, and it will surprise no one who's following this study that it has met all of those outcomes. Now, the median follow-up, as mentioned, was 42.8 months, and we see further and consistent benefit in the overall survival space, with a median overall survival of 33.6 compared to 15.9 months. The 42-month overall survival, 3.5-year overall survival rate was 44 compared to 26% with a hazard ratio of 0.53. Now, 45.1% of patients in the EV plus Pembro arm achieved a complete response compared to 32.8 in the chemotherapy arm, which is pretty high, I think, for a chemotherapy regimen. Now, 66.2% of patients who had a complete response had an initial partial response. So it is notable that the initial response does not necessarily represent the maximal response. And the conversion happened with a median of 5 additional cycles of EV. In this subgroup, the median overall survival was actually not evaluable, and greater than 80% of patients were alive at 3.5 years, as you can see here. And the numbers are actually pretty similar for patients who did not have an immediate complete response compared to all patients. So if you have a delayed CR, it doesn't necessarily seem to impact your long-term outcomes significantly. So nice and brief to get us started, Josh, but a huge update and a real step forward for urothelial cancer.
Yeah, it's a great trial. The caveats to this trial is, as always, patient selection. You know, the toxicity that comes with enfortumab vedotin, while a brilliant drug, definitely has skin toxicities. And because it's late at night, and you know, that's how I am, mostly skin toxin, neuropathy, which is huge, like 60% plus. So patient selection is key. And I think the other thing to talk about is also, it seems to be a similar theme in these bladder cancers, which is you respond initially, you're going to keep responding, like avelumab, like all of these, you know, best responders do well. What do you do with that cohort of patients who don't respond, and why?
Yeah, and I think the other thing that we shouldn't sleep on as well, while the EV obviously takes the headlines, is the Pembro, and that might be part of the sustained response that we see in immunotherapy.
Oh, such good questions. Michael, we're rampaging through this. Should I move on to our next trial?
Absolutely. I'll get the slides back up for your viewing pleasure.
Oh, you're incredible and dapper with your, you look quite like my daughter. She's in her suspender age as well.
I knew she was a young woman of terrific taste.
Yeah, I think it's something Disney. So we're going to talk about RAMPART now. And RAMPART is the fourth trial in the adjuvant world of RCC, or clear cell renal cell carcinoma. You know, this is on a background of multiple other trials. So Keynote 564, which is pembrolizumab, which did show an overall and progression-free survival, and that was published in 2024. You've got Emotion 010, atezolizumab, and Checkmate 914, which is nivolumab plus ipi-nivo. Both of those that were negative. So this trial, they'll randomize 3 to 2 to 2. Interesting randomization. So first one was active monitoring, because that was the gold standard up until 18 months ago. 13 cycles of durvalumab, or 13 cycles of durvalumab, and 2 cycles of tremelimumab. So Arm B, which was Durva, and Arm C were both compared individually to Arm A, but they're not compared to each other, which is always my bugbear, Michael, with these trials. I'm like, I want to know both. And recruitment stopped earlier than planned after the Keynote 564 trials. They were risk stratified, and that included patient size, tumor size, and histological tumor necrosis. The summary, and I'm going to just make it that we run on time today, which is a first for everything. I usually make us late. Overall survival remains immature, but there was very little difference between the two groups. So the hazard ratio for durvalumab alone was 0.99, and the hazard ratio for the combination was 0.71. There was any grade adverse event, so durvalumab plus tremelimumab, about 87%, and durvalumab alone, 88%. If you look at the higher risk cohort, when you compare Arm C versus Arm A, and for those to remember, Arm C is the one with tremelimumab, look, it was sort of the right side of that confidence interval with a hazard ratio of 0.52. And if you compare just durvalumab versus active surveillance, that sort of crossed that confidence interval as it went to 1.12. So not mature yet for an overall survival data point. And so I guess the question is, 2 points. Systemic corticosteroid use was used in almost 50% of patients. That's a lot, right? That means there's AEs going around in the combination therapy, and 30% in the durvalumab therapy. And the question is why? I'm not sure. But Michael, my take home on this trial is that it's an alternative if, for whatever reason, pembrolizumab is not the trial that you want. But I guess the question is, how does this fit into the new adjuvant space, especially with, things moving so fast? I don't know. What's your take?
I think that it's telling that the trial had to cease recruitment early when Keynote 564 came out. And it's perfectly understandable from the patient perspective. Oh, there's a proven treatment. I want that one rather than this one. I can see why it would be hard to recruit to. I think it's also interesting, and this is part of a wider question. We don't have time really to get into it now, but why is Pembro better in this space than atezo, ipi-nivo, and now durvalumab, and plus minus tremelimumab. Tremelimumab, I remember when I was a junior trainee, a consultant described as IPI's more psychotic cousin, and I suspect that is part of the reason why there was a huge amount of corticosteroid use in the combination arm. So, and if you can see that, if you're watching YouTube, that's my dog Beans, who's decided that he wants in on the conversation as well. But yeah, I think that there is. I honestly think that Durva will not have a huge amount of space, but it is a huge amount of impact in this space, I should say, because we have Pembro now. But it is an important study to do because, and the reason we put it in is because negative studies are important, and it is important that we don't subject ourselves to publication bias or result bias, because it is important that we know what works and what doesn't. And it is important with immunotherapy that we reinforce once again that they are not interchangeable. Shall we move on though? Because Josh, amazingly, we are doing quite well.
Wow. That's a first.
And I'm sorry, I'm neglecting my slide duties here. This is just to mention that, yes, as we said, the Durva and Tremi, significant issues with diarrhea and colitis. That's probably why there were so many steroids used in that arm. But moving right along, we're staying in the GU space. I have given these slides some semblance of order, but we're moving on to Talipro 3. Again, we've talked about Talipro 2. We've also talked about the PROFOUND study with olaparib, but this is in the setting of BRCA and homologous repair deficiency positive, I guess, prostate cancer. And we know that olaparib and talazoparib are both options in HRR-deficient metastatic castration-resistant prostate cancer with PROFOUND and Talipro 2. However, this is, I believe, and correct me if I'm wrong, Josh, the first study that moves the combination into the hormone-sensitive prostate cancer space. You treat more GU than I do, but this is the first study that I can recall.
Yeah, we don't generally look for HRR deficient sort of patients in the castrate-sensitive space. No, we don't.
No, but maybe we should. So this is the Talipro 3 trial design. And as you can see, it's fairly straightforward, really. You've got a combination of ADT, that goes without saying. But you have patients randomized to receive either placebo or talazoparib, 0.5 milligram, plus the usual combination of enzalutamide, which despite it being, more of an older RP, is still really the drug of choice. Now, they enrolled almost 600 patients, 599, and randomized them 1-to-1 to receive either the placebo or talazoparib. And enrolled patients had to have evidence of a loss of one of the following genes. And, there's a lot of them. HRR is a significant group, but the main ones are ATM, ATR, BRCA1 and 2, of course, CHEK2, MLH1, PALB2, and RAD51C, among others. 35% of patients had BRCA1 and 2 mutations. As we know, that's the most common and most clinically significant of these genes. 71% of patients also had high volume disease, so they're not selecting the good players here. The primary endpoint was radiological progression-free survival. And in terms of the results, well, we've got a lot of them. And apologies, there's a little text over this particular slide, but the 3-year PFS was positive for the combination, 77.6 compared to 56.2%. The median progression-free survival was not reached in the talazoparib arm compared to 45.8 months with a hazard ratio of 0.481, and this was statistically significant. And as you can see in this slide, this was significant in both the BRCA and non-BRCA HRD subgroups, which is an important distinction because they are not necessarily the same. But you can see the curves separate nicely, although the magnitude of benefit is probably greater in the BRCA arm. The interims, the overall survival, as you would expect for a prostate cancer study these days, is immature. There is a nice separation of the curves there, but it is not yet statistically significant. As you can see, it is not reached in both arms, and so we still have time to go yet. The time to PSA progression was also superior in the talazoparib arm as well. Now, this is a study. This is a slide that shows safety. So this, I believe, is the incidence of grade 3 to 4 anemia in the talazoparib arm compared to the placebo arm. And as you would expect for these sorts of PARP inhibitors, it is significantly higher. So that's the trade-off, that you have a higher rate of grade 3 to 4 treatment-related adverse events, 79 compared to 41%. And in particular, grade 3 to 4 anemia was 51% of the experimental arm. And in the combination arm, adverse events led to discontinuation in 19%. So I'm going to steal Josh's very wise point about the previous, about the EV302 study here. And I'm going to say that if you're looking at patients, I mean, number one, you have to test for them, or you should test for them, for BRCA and HRD, if you have access to the assay. But you do need to pick your patients well. And we do know that patients with high volume disease, with prostate cancer, they can get bone marrow involvement, they can get chronic inflammation that leads to anemia. But Josh, tell me, as our resident GU expert, what do you think?
Look, it's a great option. I think that's the two things I should say. This is obviously a cohort of patients which do benefit. There are still unknowns, although the interim OS data is still somewhat reassuring, but you want longer follow-up, because the thing with many prostate patients, including high volume disease patients, they live a very long time because we have really effective therapies. And it's there's also sort of intermittent unknowns about triplet therapy. And so this gives another option where toxicity wasn't actually that bad. But ultimately, testing patients early to understand their biology is hugely important, and it will become more important as we get into our 10th and our 15th season of this in several years to come. Michael, I'll move on.
We're doing well.
Doing well. ROSELLA. Brings me back to my childhood. Anyway, so relacorilant is the drug name of this trial, and it was a first-in-class selective glucocorticoid receptor antagonist that increases tumor sensitivity to chemotherapy-induced apoptosis. When I saw that line, Michael, I was like, oh, this must be a pancreatic study, because, that tumor microenvironment is such, it's not, by the way, that tumor microenvironment is such a difficult thing to penetrate. So it was previously reported that there was a statistically beneficial progression-free survival with a hazard ratio of 0.7 and an overall survival of 0.69. And this was subgroup analysis presented at ASCO. So just because I haven't actually said what the trial is about, it's for platinum-resistant epithelial ovarian, fallopian tube, and peritoneal cancer that had progressed on up to 3 lines of therapy. So a fair few, including bevacizumab. They're randomized 1-to-1 to relacorilant with nab-paclitaxel or Braxane, or nab-paclitaxel alone. So the median overall survival was 16 versus 11.9 months, which the hazard ratio is 0.69. Blows you away, right? I love this study. I feel like this should also get a standing ovation. It's, these really difficult to treat cancers. And the OS was consistent regardless of the taxane-free interval. So if there was less than 6 months from previous being exposed, the hazard ratio was 0.6, and it was 0.66 if more than 6 months. Taxane was the most recent regimen because that's what we use. And the median OS difference was 3.9 months. With a no taxane regimen, the hazard ratio was 0.63 and median overall survival difference of 4.2 months. So I think overall this is a great trial, Michael, and in a much needed space.
I agree. And look, neither of us really do a lot of ovarian cancer or a lot of gynae cancer. That's sort of how our careers have gone. But it is always really nice to see cancers that are perhaps a little bit underappreciated, getting, as it were, a Guernsey, as a previous guest of ours, James McCracken, said. And I think it is really important to take note of the taxane-free interval here, because ovarian cancer, gynae cancers in general, get a bit of an unfair reputation about, having one regimen and it's carbotaxol. But the biology of these cancers is reflected in how resistant they are or how refractory they are to a platinum and taxane-based regimen. And the fact that relacorilant maintains a benefit regardless of that is really exciting. I look forward to this agent moving up in the world, as it were, moving from the refractory and the resistant
first line.
space to sort of second or first line, and maybe joining or supplanting bevacizumab, which in ovarian cancer is a major pillar. So it's really nice to see ovarian cancer get a new exciting agent to go along with all of the immunotherapies and the TKIs.
That's it, Michael. And we're on the horizon of something exciting, but do we want to see what's next?
Yes. Well, funnily, you should say that, Josh, because absolutely true to form, our next study is Horizon. Horizon, some might say, not Horizon. Horizon, I don't know if it needs to be enunciated that way, but GEA-01. This is a study of HER2-positive gastroesophageal adenocarcinoma, gastric or gastroesophageal adenocarcinoma. Now, this accounts for about 20% of cases, depending on where you read. The standard of care for these cancers is based still, as we have said in a recent episode, on the TOGA trial, and that was published in 2010, which is cis-5FU plus trastuzumab. There has been recent studies, a keynote, I believe it was 811, that combined trastuzumab with pembrolizumab, and obviously you've got TDXD that's always lurking in the background in the HER2 positive space. But we're not talking about TDXD for Horizon, we're talking about zanidatamab, which is a HER2-targeted bispecific that binds to the extracellular domains 2 and 4 of HER2. And this has shown efficacy in preclinical studies in both the HER2 positive and HER2 low studies. So does TDXD have a bit of competition? We'll see. Patients who were enrolled had untreated, unresectable, or metastatic HER2 positive adenocarcinoma of the stomach, GOJ, or esophagus. And because HER2 positivity is, it's almost losing its meaning these days in the era of TDXD. So the definition is important. So this is an IHC score of 3+ or 2+ with a positive-ish. Pretty standard stuff, but with HER2 low and HER2 ultra low, what we define as HER2 positive is changing. PD-L1 expression was retrospectively assessed. Patients were enrolled 1:1:1 to receive, and I've got to make sure I get this right because this was actually quite confusing in the NEJM article. This was simultaneously published in NEJM, by the way. So in Arm A, patients received zanidatamab, tislelizumab, which is a PD-1 inhibitor, and chemotherapy. In Arm B, a doublet regimen, zanidatamab plus chemotherapy, and the control was trastuzumab plus chemotherapy. So it is sort of asking the Keynote 811 and zanidatamab benefit all in one. The chemotherapy was the investigator's choice of Capox or Folfox, and I've mentioned Keynote 811 in the past, and 5 seconds ago, actually, but the control arm was chosen prior to those results coming out. So this is a case of parallel thoughts rather than sort of following the leader. In terms of the results, so here we have the comparison of the triplet with the control and the doublet with the control. Much like RAMPART, the zanidatamab comparing arms weren't compared head-to-head, which I think is important, but we won't necessarily quibble. So in terms of the PFS with the triplet compared to the control, 12.4 compared to 8.1 months with a hazard ratio of 0.63. You're thinking, great, fantastic, but we still have a long way to go with gastric and GOJ cancer because the 18-month PFS was only 43.9 months in the triplet arm. So this is throwing everything we have at this cancer. In the doublet arm, very similar, 12.4 compared to 9.8 months. So the control arm in the doublet comparison actually did better than in the triplet comparison for population reasons probably, but that was still statistically significant. The overall survival was statistically significant only, unfortunately, or fortunately, I guess, for the triplet arm. It was 26.4 compared to 19.2 months, hazard ratio of 0.72, and the estimated 24-month overall survival was 54.3% compared to 38.8 in the control arm. The hazard ratio for the doublet compared to the control was 0.8, so numerically better, but did not reach statistical significance. So at this point, we're going to have to say that it's either triplet or bust for zanidatamab. In terms of safety, diarrhea was the most common adverse event and was most common in the zanidatamab containing regimens. For reference, it was 24% in the triplet arm, 20% in the doublet arm, and 12% in the control arms. Obviously, you're going to have some influence from the chemotherapy there. The discontinuation rate was also significantly higher in the zanidatamab, I am going to get that one day, containing arms, 4.1, 1.3 and 0% in the triplet, doublet, and control, respectively. Now, with HER2 receptor inhibitors, we always think about LV dysfunction, and it was numerically higher in the investigation arms, 8.8 in the triplet, 6.2 in the doublet, and 4.3 in the control. So you would say it is higher, but not significantly higher. So Josh, as I said, this was simultaneously published in NEJM. And it's a good option. I mean, access will be an issue, and TDXD, as I said, is lurking. But yes, it's something in an area of need.
Yeah, I think GAJ cancers are notoriously difficult to treat, even with TDXD. You know, sometimes people do get a good response, but it's not phenomenal. So it's great to have another option, and it will be interesting to see how we sequence these. That's the other question. Can you sequence this? Can you not? It's a bit unknown, isn't it? But I think another option, and hopefully in the future we'll see this grow and develop and become really just changing the guard with hopefully less toxicity.
It will be interesting.
Or should we
Josh,
trot along?
Yes.
Trot along?
I was going to say we are operating at optimum capacity here, but
even better.
Yes, let's trop along, as you said, to OptiTrop 05.
Yeah, all right. So OptiTrop 05 is it's a lung cancer trial. So the background of this trial is pembrolizumab is the standard of care for PD-L1 positive advanced non-small cell lung cancer based on, what was it, Keynote 24, Keynote 48, and Keynote 189. There's lots
one
of
them. One of those really low number ones here.
Yeah, and it was sort of the single agent they found benefit initially. And so, changed the paradigm of lung cancer. We have a SAC-TMT, which is a TROP2 directed ADC with a bifunctional linker. So it's somewhat similar to sacituzumab govitecan with its sort of payload, but it's got, its own proprietary linker. And, linkers are kind of the key to kind of getting these chemos into the cell. This is a planned interim analysis of the progression-free survival at ASCO. So it was randomized 1-to-1 to SAC-TMT plus pembrolizumab or pembrolizumab alone. I'm assuming in this case, and look, we don't have all the data, that you'd want to have a high PD-1, just putting it out there. But either way, it was treatment naive, locally advanced or metastatic cancer without a targetable mutation like EGFR or ALK, and positive PD-L1 expression. So PD-L1 is defined as a TPS of greater than 1%, greater than or equal to 1%. Of course, we've spoken about it so many times, Michael. None of these sort of scores are fantastic at actually being able to say if you're going to respond. Yes, there is a correlation, but it's not 100%. And they were stratified as less than 50 or greater than 50, and histology of squamous versus non-squamous. Primary endpoint, progression-free survival. Secondary endpoint was overall survival. The results, the juicy part, as I like to say. So progression-free survival was not reached versus 5.7 months with a hazard ratio of 0.35. Statistically significant. OS data is not mature, but caveat, follow-up has only been 10.5 months. The objective response rate was almost double of 70 versus 42. And in the pre-specified group, we did find benefit of that higher PD-L1 TPS score with a hazard ratio of 0.28. If it was less than 50, you had a hazard ratio of 0.28. And if it was more than 50, a hazard ratio of 0.47. And thus comes my comment where it's like TPS score is really difficult to actually identify who's going to respond well. Squamous worked really well and non-squamous not as well. There was increased grade 3 adverse events by about 20%. We'd expect that because it's Pembro versus Pembro plus an ADC. My point for this, a couple of points, and I'll let you talk, Michael, is that I think this is exciting. ADCs are going to be that next generation of chemotherapy. Do we even need to learn about chemotherapy? I don't know. My point is, would it have been a better trial to compare it to, let's say, Keynote 189 regimen, so chemotherapy plus immunotherapy, because that was the true backbone? Or are they saying because you're PD-1 positive, some people just use immunotherapy as a standalone? They probably make two take-home points, but an interesting trial nonetheless. Your thoughts?
You stole the words right out of my mouth.
I'm sorry.
No, it's good to see we're on the same wavelength. Look, I think this is a very exciting trial. I mean, yes, Sac-TMT or sacituzumab tirumotecan. We always love an ADC. And as you said, if we can spare people chemotherapy, that's ideal. But yes, this PD-L1 positive defined as a TPS of greater than 1%, I would have absolutely no compunctions if it was greater than 50%, because that's the clinical scenario in which you use pembrolizumab by itself. But if they're including people who had a PD-L1 of 1 to 49, where you would only not use chemo if there was a medical reason not to, then that, on the one hand, yes, it does raise some questions. On the other hand, the fact that there is a benefit for a chemotherapy-free regimen and, how that translates to toxicity is entirely another question. But the fact that there was still a benefit for PD-L1 low also means that, as you said, because PD-L1 TPS is not a perfect measure of response. I had a lady who had a PD-L1 of 80% recently, and she only responded for 8 or 9 months, which obviously is not what we were hoping for. So the fact that you are getting these sorts of responses for a chemotherapy regimen, the chemotherapy-free regimen, is very exciting. But
not the optimum number.
It is not optimal or optimum, in fact. And yes, we are
or Optimus.
moving, or Optimus of Prime fame. Yes. Not your best work, Josh, but that's okay. It is late as of recording. So no, our next study is the OptimUM. So we had OptiTrop, and now we're in OptimUM. And if you looked at my mistaken slide work just before, you might notice that we are coming towards OPTIMA. There was a bit of a theme at ASCO this year. But OptimUM is a study of uveal melanoma. And uveal melanoma remains a very difficult subtype to treat. Standard therapies are generally ineffective. Of course, we have had the great breakthrough with the tebentafusp for the HLA-A2 star 01. I don't exactly know how you enunciate that, but A201 positivity, but it only occurs in about 1/3 of the Caucasian population. So there is going to be a significant proportion of patients who tebentafusp doesn't work for. The OptimUM trial compared darovasertib plus crizotinib to the investigator's choice of therapy in patients with HLA-A2 negative metastatic uveal melanoma. Now, despite uveal melanoma being very rare, they managed to recruit 338 patients to the safety population, which included all patients who received at least one dose of treatment, and then 313 to the efficacy population. Patients were randomized 2-to-1 to receive darovasertib and crizotinib, which I will refer to from this point forward as D and C, or investigator's choice. So they must have been pretty confident that D and C was going to work. The control arm, just for reference, included pembrolizumab, ipi/nivo, or dacarbazine. Now, I had not treated uveal melanoma really ever, to be honest, but I'm not familiar with dacarbazine, but pembro and ipi/nivo we know about. The primary endpoint of this, which was the phase 2 component, was progression-free survival. And there will be a phase 3 component for which the primary endpoint will be overall survival. Other endpoints were overall response rate, duration of response, DCR, and safety. So the results. The median PFS with D&C was more than doubled. It was 6.9 compared to 3.1 months. Still not great, but a hell of a lot better than it used to be. This was, of course, statistically significant. The disease control rate was 73.3% compared to 31.15%. So you are getting a lot of patients with stable disease at very least. The overall response rate was 37% compared to just a shade under 6%. And in the DNC arm, 2.4% had a complete response and 34% had a partial response. So you're still getting a pretty good hit rate amidst that DCR of 73%. The overall survival is immature, which for my money is an achievement in and of itself when you're talking about metastatic uveal melanoma. In terms of treatment-related adverse events, the most common, fairly standard with the DNC group, diarrhea, nausea, and vomiting, but the one that caught my attention was edema, something to watch out for. And in terms of the grade 3 and 4 treatment-related adverse events, diarrhea was again the most common, but the other thing to look out for is syncope with the DNC regimen. AEs led to the discontinuation of darovasertib in 3.8% and crizotinib in 10.9% of patients. So overall, not a bad tolerated regimen for a significant benefit in an area of need.
My points to this, Michael, is, I've actually treated a fair bit of uveal. I don't do much these days, but I was at a high volume center several years ago. I always found this combination actually somewhat toxic. Like, the edema is quite difficult to manage. And you need opt-out review and those sorts of things. And look, yes, there are no other options for uveal melanoma. So this is not you shouldn't have this. This is great that we have this option. I do think that we probably need better tolerated drugs, but I appreciate that I haven't gone through the stats of what the AEs and the dosing schedule were, so maybe they've sort of refined that over time, but that would be probably my only point.
Yeah, and when we've come across so many times where we say, or we know a regimen is toxic, but the studies say it was well tolerated. FLOT, for example, in the gastric space. Keynote 522 is another one. Yeah, exactly. I think
notorious.
It is notorious, but given the alternatives or lack thereof, it is.
It's still a great regimen, and I think once you can select the patient and manage their tox, it's actually okay. It's just you have these sort of situations where you're like, you just didn't manage it. And overall, it is a good drug regimen. So please, if someone says to do it, do it.
Our next study is the final in our trio of OPTIM studies, Josh. But it's a good one.
Yeah, I feel like I'm the victor for today, but let's talk about OPTIMA, Michael. OPTIMA is somewhat showing us that maybe we need to be better at patient selection. That's the summary. But the background is the role of chemotherapy in adjuvant breast cancer has been questioned in the HER2 positive and the triple negative spaces. Now, for context, that's all given neoadjuvantly. The benefit of chemotherapy does remain unclear in sort of the hormone receptor positive space, but is somewhat given in high-risk cases. And what I mean by that, we give it because we know there's a lot of data to support it, but the world's moved from looking at lymph nodes and tumor size and grades to kind of being a bit more complex. Australia doesn't have it, but there's a number of gene assays around, which are great, but there's Prosigna, and this is a trial about Prosigna in the premenopausal women, which is a 50 gene expression assay that produces a risk of recurrence score, with the idea that being if you have a high risk of recurrence, you give chemo to reduce that risk. And if you have a low risk recurrence, maybe we can exclude chemotherapy and just give endocrine therapy. This was a big trial, 4,429 patients, men and women over the age of 40, who were recommended to receive chemotherapy. You were included if you had 0 to 9 lymph nodes involved and a tumor size of greater than 30 millimeters if there was N0. Literally had someone last week in this case, Michael, and I was like, this could be the ideal kind of conversational point. They're randomized to standard of care chemotherapy, being that of chemoendocrine therapy, or then randomized to the Prosigna test-directed chemotherapy. If your Prosigna was greater than 60, you were assigned to chemoendocrine therapy, while those with the less than 60 were receiving endocrine therapy alone. It included ovarian suppression in the premenopausal patients. Patients receiving chemoendocrine therapy were blinded to the randomization. The primary endpoint was a non-inferiority of the 5-year invasive breast cancer free survival, so IBCFS, with 3% margin. Median follow-up was 3.9 years with a maximum of 6 years. and 141 events had occurred in the control arm and 139 in the test-directed arm. So there were 66% distant recurrences. The 5-year IBCFS was 91.5% in the control and 90.4% in the test arm. Remember, it's a non-inferiority with a hazard ratio of 0.99, so it's not statistically significant. And then in the low risk of recurrence cohort, the 5-year IBCFS was 94.9% versus 93.7% with a hazard ratio of 1.06 with a p-value of 0.0051. And there was no significant heterogeneity. I thought there was another one for the high risk, Michael. Maybe there isn't, but I don't have the paper in front of me. Either way, the summary is I think I was listening to a talk, and about 2/3 of patients we could potentially omit chemotherapy if we use something like Prosigna. I have more thoughts, but if you want to say something, I'll let you.
No, you're on a roll if you've got thoughts. I'll let you go.
I think the things are, it's sort of up to 6 years of follow-up. So do we need more follow-up? That's kind of my first question. The cost in Australia, Prosigna costs about $3,300. So there's obviously the financial toxicity is not funded by the government here. And so I guess they're the two main things. And the other thing is we do have distant recurrences of breast cancer. So does that mean what's the 10-year outcome for this? What's the 15-year? We know it's not inferior in the low risk of recurrence, right? So great, I'll give you endocrine therapy. And I think I'd be relatively comfortable doing that. But would I squirm a little bit if you've got a really, really high risk cancer? Maybe. I'd be like, it worry me a little bit. I guess that's it.
This is a really interesting study, and it is sort of, as you say, it is symptomatic of a world that has moved far beyond AC Taxol, and that is sort of happening for breast cancer writ large. You said you had a case that would have fit into this just this week. Every single week when I'm in breast clinic, it's just like, do I give this patient chemo? How much are they actually benefiting from? We have the NHS Predict, which can spit out numbers, but those numbers don't really necessarily have a tangible benefit. So I think having this Prosigna would be very useful. It's very much like sort of ctDNA in the dynamic study in the colorectal space, where we can take from this study that it is non-inferior. We can use it as a guide. I think to add to your point, I completely agree about the long-term follow-up. This is hormone receptor positive breast cancer, so you have those 10 to 15-year recurrences. The other thing as well, as you mentioned, this study enrolled people who have up to 9 positive axillary lymph nodes. Where do CDKs fit into this? I'm assuming that if you had sort of a high-risk cancer that had a low risk of recurrence score on a Prosigna, you would give them endocrine therapy plus a CDK still, because the question is chemo or no chemo. So, but that's sort of another area where there are potentially some unanswered questions. And they might have started this study before the data from Natalie and Monarchy came out. But that would be another question. And if I had access to it, I'd say, great, no AC Taxol for you, no problems with your heart. But at the same time, I'm not going to stop giving you a adjuvant CDK.
I agree. I think more is still good when it comes to non-chemo options, but I think the victor of this generation will not be chemotherapy. It will be the precision medicine, which we are entering the golden era of.
It's very exciting. And, I tell patients all the time that oncologists hate chemotherapy, really, these days, and we only give it because we have no other choice. But to your point, the victor or Victoria is going to be precision medicine. And we have another precision medicine study, which is another breast cancer study, specifically looking at PIK3 kinase mutations. Now, these are present in about 1/3 of breast cancer cases, and they're especially common in the luminal and HER2 subtypes. And they represent a common mechanism of endocrine resistant in particularly endocrine receptor positive breast cancers. Now, I've been practicing all week to try and get this right, but I'll give it my best shot. Gedatolisib is a is an agent that can block potentially all 4 PIK3 kinase isoforms and mTORC1/2 in the PIK3 kinase AKT-mTOR pathway, which we know is a major pathway in the progression and resistance of breast cancer. So this study was a study that examined the combination of fulvestrant and gedatolisib plus minus a CDK4/6, and this had already demonstrated PFS benefit in patients with PIK3 kinase wild-type breast cancer. I'm not afraid to admit that this study tripped me up a bit. I did all these notes on Victoria 1 only to find out that it was the PIK3 kinase wild-type study that was published, I think, earlier this year. But this study presented at ASCO, or the sub-study presented at ASCO, is focusing on the PIK3 kinase wild-type population. Randomized 362 patients, and they were randomized 3 to 3 to 1. This is another triple-arm study, Josh. We've got a few of those today. And it compared, again, much like Horizon, it compared a triplet, a doublet, and a control arm. In this case, the triplet arm was gedatolisib plus palbociclib plus fulvestrant. Fulvestrant plus gedatolisib without the palbociclib, and fulvestrant plus apellisib, which is another PIK3 kinase inhibitor that is used. It's not used so much in Australia because it's not approved, but it's used, I think, overseas. And it was this study enrolled patients with hormone receptor positive, HER2 negative, PIK3 kinase mutant breast cancer. And patients had to have progressive disease after or during an AI and CDK4/6 in the first line. So this is a second line study. The primary endpoint was the PFS of the triplet compared to the control. Secondary endpoints were the PFS for the doublet related to the control, overall survival, objective response rate, and safety. As we can see, the PFS was positive in the triplet arm compared to the control, 11.1 compared to 5.6 months with a hazard ratio of 0.5. In terms of the PFS for the doublet, this was also positive, 11.3 months compared to 5.6 months with a hazard ratio of 0.51. In terms of safety, there were lower rates of all-grade hyperglycemia, which I gather is a side effect for apellisib in the triplet and doublet arms, 15, 11.5, and then 58% in the control arm, as well as diarrhea, 15, 9.6, and 40%. So that apellisib is a toxic old drug. However, there were higher rates of stomatitis with gedatolisib, so 61%, 61%, and 34%. So probably a bit of a wash depending on what sort of toxicity your patient encounters. But look, I think that on the one hand, this is yet another agent for breast cancer. It is very exciting. This is an important and I was about to say undervalued, that's not true, but under-recognized subtype, at least in Australia, of breast cancer patients. I wonder, Josh, if we're headed for a sort of a beacon colorectal cancer type situation here where the doublet is deemed to be just as good, if not better, than the triplet. And I wonder whether that's what will happen. We have PFS data, but we will eagerly await the overall survival data, which it will surprise no one to hear was immature.
It is an interesting trial. When I say that it's, the whole issue with blocking PRC3 kinase, there's just all these other pathways that get activated. So it works for a time and it doesn't. So having something that blocks all of them, curious. Interesting thing that, lower rates of tox, but you said high rates of stomatitis, so it's kind of like you think if you've got more mechanisms of action, it'd be worse. Caveats, they use palbociclib in this. Again, I think when you look at statistical analysis, maybe it is better, maybe it isn't. There's a spectrum where most people go with ribo or abemaciclib, but even so, when you see this added to other drug combinations, you get positive outcomes. So take that what you will. There's no data with ribo to kind of compare that to. So obviously this drug was probably designed several years ago, if not earlier. But it's really promising. And, if it ends up being as good as this looks, where does it move to? First line?
Well, yeah, I mean, do we start testing for PIK3 kinase mutations at the start? I mean, it is a resistance mechanism, so it might be the case that second line is all it is. But hey, TDXD at this point in Australia, at least, is second line. That's what it's approved for, and it's a damn good drug. So maybe it's not so bad to have a really solid option in second line for people who develop these mutations. Josh, we're doing really well. Our penultimate study.
Oh, penultimate study, and we are under an hour. Okay, so we've got isolantamab brengatican. Wow. In metastatic triple negative breast cancer. So background, triple negative breast cancer is hard to treat despite an evolving field of newer drugs coming out. Affects younger women, it's more aggressive, it's difficult. So this was a first in-class bispecific, so two, ADC targeting both EGFR and HER3 with a topoisomerase 1 inhibitor payload. Classic payload, but different targeting agents. This was a pre-planned interim analysis. So 418 patients randomized to Isabren or physician choice after 1 to 2 prior lines of therapy. Prior lines may include a taxane. Treatment physician includes Ribulin, capecitabine, etc. Stratification, prior lines of therapy, prior anti-PD-1, and HER2 IHC. Interesting they haven't used prior ADC. Primary endpoint was progression-free survival. Median, they probably could have done overall survival. I'm just putting that out there. I know we haven't talked about the results, Michael, but I think in this cohort of patients, I want an overall survival benefit. So the median follow-up was 11 months. Progression-free survival median was 8.5 versus 3.1. So crazy hazard ratio of 0.29, and median OS survival, which is actually also now statistically significant after I said that, was 15.9 versus 12.5 months, with a hazard ratio of 0.5 and a p-value of 0.0019 and objective response rate that was 2.5 times that of its closest chemotherapy counterpart of 50 versus 20%. So grade 3 AEs, neutropenia, thrombocytopenia, interstitial lung disease was reported in 3 patients, so not huge and far less than something like TDXD, and treatment discontinuation rates were low. My thoughts on this, Michael, is that that's really exciting. It's really promising. I'd like some longer follow-up to see what happens. I'd like to understand where it sits first. Let's say sacituzumab govitecan, right? It's triple negative. That's usually the second line after carbogem pembro. And whether you would use something like this or look for a targeted mutation.
Yes, and once again, Josh, you are living rent-free in my brain because
I've done that before.
Yeah. Yes. I'm pretty sure you paid rent that time, but that's fine. But yeah, so I mean, the elephant in the room, as you said, is sacituzumab govitecan. We have the ASCENT trial, and we commonly use SG in these spaces, either for patients who are HER2 absolutely zero, and so therefore don't qualify for TDXD, or post TDXD. And I think that having SG, and again, we don't know when Isabren was developed, but not having SG as an option does, or mandating it as a previous treatment does raise questions about sequencing. And they are different targets, but this is a question that I think we're going to have to confront in this era of ADCs and targeted therapies. Is if you have an ADC that maybe has a similar payload but has a different target, can you sequence them one after the other? And what does that cumulative toxicity look like? I think it is never a bad thing to have more options. And I know that there is a phase 3 study of Isabren plus Pembro in the first line. We had Ascento 4, or Ascento 3, I can't remember which one, recently read out, which was SG plus Pembro. So it will be interesting to see how all of these new agents fit in. And even if do they fit in, can they coexist, or is one going to eat the other? We don't know. Unknown, TBD. But I think that if you do have a patient, perhaps a patient who, one thing that Isabren didn't seem to have is diarrhea, and we know that SASI can cause significant diarrhea amongst other things. So this might be a case of picking your patients and base your choice on what they want. We're up to our final trial, and Josh, I think we deserve to give ourselves a pat on the back at how efficient we have been.
So
An hour,
efficient.
so efficient, so efficient. But our last study is something completely different, as John Cleese was fond of saying. And this is a study of lifestyle intervention in breast cancer. The reason this interests me is because I love a good lifestyle intervention. After the data from Challenge in the colorectal cancer space really shone a light on it, I really do enjoy these sorts of studies because lifestyle intervention is really a zero risk option, or a zero risk recommendation that we can make to our patients when we're so sick of talking about the risk of ILD and diarrhea and hyperglycemia and edema with all of our other drugs. So this was an Italian study of a low GI Mediterranean diet in conjunction with daily walking and vitamin D supplementation in women with stage 1 to 3, obviously, by definition, non-metastatic breast cancer, living in several different parts of Italy. The aim was for weight loss and metabolic syndrome remission because there is evidence that associates this with improved breast cancer outcomes. Randomized almost 500 patients to standard advice, the control arm, versus, quote, intensive advice, and that's a direct quote from the study, regarding low GI diet and engaging in 30 minutes per day of brisk walking beyond the regular physical activity. So this is the first difference between this and Challenge, where Challenge was a very intense, professionally led exercise regimen. This is simply 30 minutes of brisk walking. you can define brisk, I guess, however you want. Both groups did receive vitamin D supplementation. The primary endpoint was the breast cancer recurrence at 33 months. And I don't really know why they picked 33 months as a number. It seems a bit arbitrary to me, but I'm sure they had their reasons. The secondary endpoints, which weren't necessarily, I don't think they were read out at ASCO, was the management of cardiometabolic risk factors. So of these patients, 86% of patients had stage 1 to 2B disease. And that's important to say because these are patients that are probably going to do well anyway. 75% had hormone receptor positive disease. And while there were no differences in recurrence rates between the arms in the intention to treat population, there were only 37 recurrences in total. And this is where we come back to that 33 months of follow-up, probably a bit too short. However, they isolated women with a hormone receptor positive breast cancer who were more adherent to the intervention program. And this was 41% of the total population in the intervention arm. And these patients had a 76% lower risk of breast cancer recurrence, hazard ratio of 0.24. There were higher rates of weight loss, and the presence of metabolic syndrome dropped by 65% in the intervention arm and 34% in the control arms, and that was statistically significant. So, I mean, Josh, look, this is a study that I think if it was for an intervention that had side effects, we wouldn't be putting it in our episode of Agents for the Present. But because, number one, let's remember that women with early breast cancer, the majority of them are cured with surgery and with adjuvant or neoadjuvant regimens. Number two is that if these women are cured, then they have often decades of life expectancy. And so focusing, and you know, we have had episodes previously talking about cancer survivorship, and this is an increasing area of focus for many oncologists. And so putting the focus away from the patient's cancer and towards their overall health, while simultaneously, if this study is to be believed, and, you know, caveat, there are a lot of questions about the methods in the study, but if this is to be believed, simultaneously reducing the risk of breast cancer recurrence, this is, to me, the very definition of a no-lose scenario.
Yeah, I agree with you, Michael. It's a no-lose scenario just based on the data. I guess the question is it a bit of an artificial scenario that you've how do you follow this up? Like, is it all based on surveys and what's the assessment of that? And it's kind of that selection bias, like you're in the intervention arm, so you're going to do so much 30 minutes. And you're in the slightly less intervention arm. You've got to have some pasta. Like, I love pasta. I bought some yesterday at the shops.
Oh, dear. But yes, and the other thing, I guess, is what does intensive advice constitute? Is it basically you screaming at your patient, telling them to do 30 minutes? Like, it's not as rigorous as challenge, but I guess that also maybe makes it a bit more applicable just in general conversation. Hey, go for 30 minutes of walking extra every day. It'll do you good.
I think the summary is that if you do exercise, it is good for you, and if you lose weight, it is good for you. So please do that. The Italians have it right.
Yes. Yeah. I always tell patients there is absolutely, I will never say no to exercise and dieting.
There we go, Michael. And we're on an hour, so we're going to cut it there. Guys, we'll see you next time for our second episode of ASCO.
And might not be as long.
Maybe not. We'll see you then. Bye.
Maybe not. We'll see you then. Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions, with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.